You're listening to Medscape's In Discussion series on hidradenitis suppurativa, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Drs Okoye. Dr. Okoye is professor and chair of dermatology at Howard University College of Medicine. Relevant disclosures can be found with the episode show notes on medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello, I'm Dr. Drs Okoye. Welcome to the Medscape in Discussion podcast series on hidradenitis suppurativa. Today, we'll discuss HS and pregnancy with our guest, Dr. Shari Lawson. Dr. Lawson is an associate professor of obstetrics and gynecology and the John F.J. Clark, MD, endowed chair in the Department of OBGYN at Howard University's College of Medicine. Thank you for joining us today, Dr. Lawson, and welcome to the Medscape in Discussion podcast.
Thank you, Dr. Okoye. I'm looking forward to our conversation today.
I suspect that OBGYNs see more HS than dermatologists do. Yet, I haven't seen many forums where OBs and derms get together to discuss HS. So I think this is a fantastic opportunity. I'm so glad that you could join us. Now, we know that HS is more common in women, and the disease tends to be more active during their childbearing years. And I know that you've seen quite a bit of HS in your patients. So why don't we start with that? Tell us, just give us some insights from your perspective about how this disease affects your patients and even affects your decision making as their OB during pregnancy and even at delivery.
Absolutely, Dr. Okoye. I was so excited for the opportunity to talk with you about this topic because I do see a lot of HS in my practice. I'm a general OBGYN, and so while I do take care of pregnant women, I also engage in a not insignificant amount of well woman care. And as part of the well woman exam, we will generally do a breast exam, also examining the breast tissue that extends up and towards the axilla. And we also check the axilla for swollen lymph nodes or lymphadenopathy, just as part as our normal well woman exam, in addition to doing a vulvar exam and part of the pelvic exam for pap smear screening. And so I do find in my practice, oftentimes, nodules, small sinus tracts, scarring, and then the double comedones that are commonly seen in the disease. And frequently, patients may not know that they have some of the stigmata associated with HS. And I'm oftentimes the first person that's pointing it out to them.
Wow. I think that's a real big issue with HS where patients come to care years into their disease and they've seen many providers, including OBGYN, emergency room, and no one named the disease for them. So I'm glad to hear that you are giving them a name and hopefully starting therapy and sending them on to Derm. Let's talk more about the hormonal aspects of HS in your GYN patients. We don't really understand fully the hormonal contribution to the pathogenesis of HS, but we know that that is an issue in HS. It starts after puberty. The activity of the disease tends to decrease after menopause. Some people have increased activity about a week before their menses. And so maybe it's androgens, but we don't know. Is there a role for estrogen, progesterone? Clearly, you live in this world, right? You think about estrogen, progesterone, and androgens all the time. Can you give us a little bit of insight into how these hormones might affect inflammation and how they change during pregnancy, since we know the disease tends to get a little bit quieter in pregnancy?
So, certainly, there can be some conversations around how estrogen and progesterone can have an impact during the menstrual cycle as well as during pregnancy. So, progesterone is known to suppress the immune system somewhat during pregnancy. It's not uncommon for patients that have disorders of systemic inflammation. The most common one that we see is lupus. And in pregnancy, frequently patients will have a little bit of a remission or their symptoms will not be as severe, but then they might have a flare immediately postpartum. Maybe something that you see similarly in HS patients where they don't have as significant as a disease burden during pregnancy, but then it worsens in the immediate postpartum period.
Yeah, that's exactly what we see. I mean, it doesn't occur in all patients, but in my experience, in most patients. So that's interesting. So it may be related to this immunosuppressive role of progesterone. That's super interesting to me because I also believe when we treat patients with progesterone only contraceptives, they tend to worsen. Some of them, their disease worsens. So I suppose that is related to the inherent difference between our endogenous progesterone and exogenous progesterone.
It's actually interesting that you mentioned that. So, the progesterone type that you're using in your contraception, it can vary. And so, one common type of progesterone contraception that's used are the levonorgestrel IUDs. And so levonorgestrel is an excellent progesterone for contraception. The way that the IUDs work is that it does suppress the endometrium. It also has some effects on sperm motility. It causes some localized inflammation that prevents implantation. But the levonorgestrel is actually a derivative of testosterone. And so it does have more androgenic properties. There are other progesterones that have less androgenic or even anti androgenic properties that might be preferable for your patients if you think that there's a link between androgens and the activity of HS.
Okay, so that's interesting. I mean, I believe, I've read that levonorgestrel has a higher androgenic potential, but I didn't realize it was derived from testosterone. So that's, I think, really good information for our derm colleagues. Can you tell us some of the anti-androgenic or lower androgenic progesterones we should try?
Yeah, absolutely. So a common one is drospirenone. That is a progesterone used in some of the combined oral contraceptive pills. It actually has more of a relationship to spironolactone, which I believe is another medication that you sometimes use in HS because of its anti-androgenic properties. The other thing is that when you're using combined oral contraceptive pills, you have a component of estrogen. The presence of estrogen promotes increased circulating levels of sex hormone binding globulin, or SHBG for short. And SHBG will also bind androgen, circulating androgen. So using combined oral contraceptive pills are actually really helpful in decreasing some of the androgenic effects of circulating hormones. But if you're using an IUD, for example, that's just going to be progesterone by itself.
And so that makes sense then why combined OCPs are used for things like PCOS. You mentioned that in other inflammatory disorders, in patients who improve during pregnancy, they'll often have a postpartum flare. And we've seen that in patients with HS as well. However, one of the issues I've come across is it's actually pretty difficult for the patient to get their biologic in that postpartum period while they're in the hospital. Do you have any suggestions for how dermatologists can best partner with OBGYN to make that happen?
The first question that I would ask is, are there treatments that the patient should be continuing on? And that might require some collaboration during the pregnancy, because there may be some medications and some treatments that the dermatologist and the obstetrician can agree on, not necessarily trying to restart or reorder a brand new medication during that short, 2 to 3 days that they're with us postpartum.
Great. I like the way you're thinking because I think many of us, once the patient becomes pregnant, we just throw our hands up and say, "Okay, we can't treat you with anything. Nothing is safe. We don't want to mess with you or your baby." So I'm glad to hear that there are options that you would be willing to collaborate on. So let's talk about some of those. I mean, I know that there are some that are absolutely contraindicated, like spironolactone, finasteride. But what about antibiotics? Are there specific antibiotics that you would prefer?
So, first thing I want to say is that it's not only on the physician side that there's kind of this haste to discontinue all medications, it's also on the patient side. Frequently, patients they find out that they're pregnant and they immediately stop whatever medications they're taking because they want to do the right thing for their pregnancy. But it's really important to understand that having a healthy mom whose medical conditions are optimized and well controlled during their pregnancy is oftentimes the best thing for the pregnancy. And so it's physicians and patients that are stopping their medications. But the other thing I say is to the patients, please just ask your doctor to reach out to the OBGYN that's caring for you if they have questions about whatever medications. There are a number of antibiotics that are safe in pregnancy. We frequently get questions about antibiotics that can be used for dental procedures, for ear infections, and so the penicillins are fine. We can also use macrolides. So we use azithromycin and erythromycin in pregnancy. We can also use clindamycin in the second and third trimester. We use the cephalosporins as well. We do try to avoid, if needed, we can certainly use fluoroquinolines sometimes, particularly in our patients with cystic fibrosis. We often will use that for them. We don't usually use fluoroquinolones in pregnancy. We try to avoid that, but many of the other oral antibiotics can be used. We try to also avoid any of the tetracyclines. So doxycycline, for example, to avoid that in pregnancy.
Okay, so lots of options there. And I know metformin, which we use as an adjunct in HS, I know that's safe in pregnancy since, we use that for gestational diabetes. Well, what about the biologics? So we have three FDA approved biologics for HS at this time: adalimumab, secukinumab, and bimekizumab. What are your thoughts on the biologics during pregnancy?
There's no evidence that there is any harm in using or continuing on biologics in pregnancy. But I think, like many medications, because there haven't really been studies that actively include pregnant patients, people are often reticent to use them. They feel as though they don't know much about it. But there are other disorders that patients might use biologics during pregnancy. Common one is multiple sclerosis, for example. And again, these medications can oftentimes be continued just with the approval discussion with the OBGYN, just to understand how severe their disease is and what other medications, other comorbidities they may have. But oftentimes we can continue on these same medications.
Yeah, and to your point, if mom is doing well, if her inflammation is under control, then the pregnancy will probably do better. That's one way I've been able to discuss it with patients. And I think it's worth kind of calling out that another biologic, certolizumab, doesn't cross the placenta. So in the derm sphere, we usually say that's the ideal biologic, but it's not approved for HS, so it's much harder to obtain practically. So it's good to hear that from your perspective, we should discuss with the patient's OBGYN, but it may be okay to continue. And speaking of raising alarms, I often wonder, when a patient presents for delivery, the labor and delivery team may see these active lesions or even inactive lesions of HS on the vulva, the perineum, and get really concerned that this may be something else and maybe something dangerous for the baby. And I've always wondered if that contributes to the higher prevalence of C-sections in our patients with HS. What are your thoughts on that? Why do you think patients with HS tend to get more C-sections, and why?
Absolutely. And I think that also, given the presentation of HS, so frequently patients may present with boils or ones that are draining. There's often concern about sexually transmitted infections in pregnancy. And so it's helpful to know that a patient has a diagnosis of HS, and also to know that we can keep it relatively well controlled to probably also cut down on their flares during pregnancy as well, which can sometimes raise alarm. I don't know the literature about the relative frequency of C-sections in patients with HS versus ones who don't have HS. So I'll have to take your word on that. But I will tell you that it is one of the things that we are looking for when we're conducting those examinations when a patient is presenting to labor and delivery. We're particularly looking for genital lesions. In specific, we're looking for any signs of herpes simplex because neonatal herpes encephalitis is a devastating disorder. The risk to an infant increases several times over if they are delivered vaginally and there's an active or even a prodromal herpes infection. So we do look for any painful nodules, any vesicles, ulcerations, draining, pain in that area, particularly in patients who don't know that they have a diagnosis of HS. The way that they discuss their disorder, they might say, yes, sometimes I feel something there, it's painful, and then it ruptures, it's draining, it's really tender. So they may be describing it one way, but the provider might be biased towards thinking, oh no, this might be HSV. And the delivery mode of choice for active HSV or prodromal is first by C-section because of that risk.
That makes sense. And I guess, everybody prefers to be safe than sorry. Well, Dr. Lawson, are there any other points you'd like to raise?
I just like for people to, use the opportunities that arise when you're caring for non-pregnant patients. And, when you see the exam, sometimes I'll see evidence of HS on the breast exam, particularly near like the inframammary fold or in the inframammary cleft. To just start to have a conversation with a patient, asking them, have you noticed any differences in your skin in this area? Have you noticed anything in the axilla or under your armpit? Because frequently people are really embarrassed about HS. They're afraid that it's a sign that they're dirty, they're not cleaning themselves properly. Very often people say that, since they were 12 or 13, their parents had them using very harsh soaps and antibacterial soaps because they seem to keep getting all these boils. There's a lot of shame around this disorder. And so I think that it's an opportunity for us to really educate the patients at a time where they're not expecting it. They're not pregnant yet. They're just coming in maybe because they're having an annual examination and you notice it. And so it's an opportunity to talk with them about it, to help to eliminate those feelings and to refer them for treatment so that we can get it under control. So that way we're not addressing it for the very first time in pregnancy where people may have had difficulty conceiving or maybe they've had a complicated pregnancy. And now you're saying, well, I want to put you on these medications. I want to put you on these antibiotics or different treatments. People are very reluctant to start new treatments and new medications during pregnancy because they're very concerned. They're afraid to even get their nails done or get their hair done. So they're very concerned about affecting their pregnancy. And so I think that the opportunity really exists outside of pregnancy.
Well, that was really well said. I couldn't agree more. Thank you so much for joining us, Dr. Lawson. Today, we've talked to Dr. Lawson about HS and pregnancy. And, there are a few takeaways that I got from this conversation. The first is that combined oral contraceptive therapy may be much better for patients with HS than the progesterone alone IUDs. And most importantly, conversations between dermatologists and OBGYNs are really important before our patients conceive and certainly during pregnancy as we try to make sure they have the best outcomes. Thank you for joining us. Please take a moment to download the Medscape app to listen and subscribe to this podcast series on hidradenitis suppurativa. This is Dr. Jeanette Okoye for the Medscape In Discussion podcast.
Thanks for listening to Medscape's In Discussion Hidradenitis Suppurativa podcast series with our host, Dr. Jeanette Okoye. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com or the Medscape app for show notes, links, and more information on hidradenitis suppurativa.